traffic itself. And the other encephalitic manifestations include hallucinations, ataxia. Seizures are not that common, and sometimes occasionally that has been associated with focal weaknesses. And the other form is the limbic form, or the next slide we'll find about the limbic encephalitis, which is actually responsible for the behavioral abnormality. Sorry, this one is talking about the paralytic rabies. And in paralytic rabies, what happens is the picture is almost similar to a Guillain-Barré syndrome, where there will be significant amount of limb weakness. And limb weakness usually starts again from the site of bite. That means if the, let us say, if the right lower limb is affected, you has been bitten, the weakness will start from that area usually. This can actually have an overlap with the encephalitic form as well. And sometimes these patients remain in coma for 1 week, and then usually they die of symptoms of neurological symptoms and associated with respiratory paralysis. And there have been instances where rabies have even been suspected after that. Okay, I think one slide is missing somewhere. The other one is actually was talking about the limbic encephalitis. What happens in limbic encephalitis is that the patients will develop emotional disturbances. Limbic system, as we know, is dealing with emotions. And what happens in limbic encephalitis is a situation where the patient will start behaving in an aggressive manner, in an agitated manner. And periods of violence and periods of calmness come in between. And the patient can become absolutely normal in between, and in between he becomes violent and starts becoming agitated and all, and he starts even disturbing people around. But the moment the patient becomes conscious, the moment the patient becomes calm and quiet, he is aware of whatever has happened before, and sometimes occasionally patients have been even regretful about that. So that sort of a limbic encephalitis will also be associated with autonomic disturbances, where the patients can develop tachycardia, patients can develop paraplegia, tachycardia, paroxysmal episodes of cardiac arrhythmias. This can be associated with piloerection. This can be occasionally be associated with priapism and dilatation of the pupils, dysphagia, and all those things can happen because of the involvement of the autonomic system. So this is this picture actually right now on the screen shows how things progress in furious rabies as well as in paralytic rabies. The prodromal symptoms might look almost alike with fever and paresthesia, but subsequently the symptoms will actually change. In the furious rabies, the person actually becomes over agitated and anxious and restless and with having emotional disturbances, whereas in the paralytic form, they usually develop neurological manifestations which may be localized or sometimes generalized. In any case, the patient progresses to coma, and usually this person's die of respiratory involvement, and death occurs in a matter of about 1 to 7 days. Now, these are the standard case definitions which have been, put in our national guidelines, the National Action Plan as well, which speaks about the definition for a suspect case, which is actually the death of a human with a history of dog bite preceding in the previous few months. And in a probable case, this is a suspected case plus a history of exposure to a rabid animal, and exposure has been defined there with various features, including unprovoked aggression, and then hypersalivation, lethargy, and all those types of abnormal activities in the animals. In the next slide, we speak about the laboratory confirmed case. This is a case in which is a probable clinical human case that is associated with the laboratory confirmation. We have a detailed discussion on laboratory confirmation in the next presentation, so I'm not going to the details of all those things. So there are different tests which we can use to identify the presence of viral antigens as well as various other positive tests which are possible, about which we will be discussing in the next session. Next slide. Yeah, these are the antemortem specimens that can be sent for investigations, about which also I'm sure the next speaker will be elaborating much. Now comes the issue about management. A few years back, perhaps a few decades back onwards, the management of rabies was actually highly non-specific, where the patients were put into the so-called uncomfortable rabies cells, which are still seen in some of the hospitals where the patients used to be locked up almost like a lockup in custody, where the patient was practically not attended to. But we know that this is a situation where the patient is having a lot of difficulties and the patient is experiencing a lot of discomfort. And we know that the patient is going to die in most instances. If the diagnosis is certain, the patient is going to die almost in a period of 1 week. So we have actually started giving ICU support for these patients. So these patients can be kept in ICUs. They can be hydrated properly. If they are having wound-related problems, that can be addressed too. If they're having respiratory infections and other things, we need not leave them alone. So all these patients can be treated with supportive measures. They can be managed in almost all hospitals. Only thing is there must be care for monitoring the patient carefully, and supportive care must be properly given to them. And in occasional instances, as our introductory remark has said, it is possible that they may occasionally survive out of rabies, but the survival patterns are obviously not going to be very comfortable. Uh, with good ICU support, it is possible that these patients can sometimes live for a few weeks, occasionally has been reported for a few months. But general rule is that most of them will die in a period of about 96 hours to 1 week's time. Now, in the management, there have been two protocols which have been found to be successful, at least on an experimental basis. One is the Milwaukee protocol, in which the patient is induced into a coma for a period of a few weeks, during which time we expect that the central nervous system neurotransmitter dysfunction will completely disappear. And occasionally, this has been associated with administration of antiviral drugs, that is usage of amantadine, and the patient is always under sedation and they are suppressed with the respiratory support using ketamine and other things. And it is assumed that with suppressed brain activity, there will be minimal damage and the immune system is given more time to fight off the infection on its own. And occasionally, this has been found to be useful. And there have been reports, as you can see in the next slide. Uh, uh, there has been, a low success rate, but the high costs and ethical debates associated with this, because in most instances, the patients do not return back to a normal life, but they are just kept alive. So this is not having widespread acceptance, and this is probably an unlikely option for an extensive use. In addition to the Milwaukee protocol, we had another protocol which was suggested, which is called as the Rabies protocol, where in order to avoid the immunomodulation that is likely to happen when the patient is in coma for a pretty long period, here the sedation is removed early. Actually, you look at the titration of the neutralizing antibodies. Yes, the patients usually develop antibodies to the rabies virus in the CSF, and you look for the antibodies in the CSF, and as soon as they start developing antibodies, the sedation is gradually withdrawn, and more attention is paid to the fluid and electrolyte balance. But still, we do not have any good, supportive results which had come out of even the use of these two protocols. These are the only two protocols that have been actually highlighted specifically the management of rabies. Going on to the next slide, we can have a quick look at what is happening about rabies in animals. As we all know, in animals, there are different types of manifestations, and these are the case definitions for suspected, probable, and confirmed cases of animals. And please look at the last one, which actually tells you that a suspected or probable case that is ruled out by laboratory tests or epidemiological investigation, in which comes the appropriate quarantine period in eligible animals. This quarantine period is usually depicted as a period of 10 days from the date of bite, during which time the animal must be observed carefully for any abnormal behavior. And if the animal is alive on the 10th day, we can actually say that this animal bite at that stage has not transmitted the virus to the human being. So these are the cases which are referred to as in the table as not a case. That means the appropriate quarantine period is over. Now, the rabies in animals can have different clinical manifestations. Actually, we are not going to the details of all those different clinical manifestations, but the one we have to focus mainly is on the dogs and cats, where you can have the furious form with aggression or the dumb form with the typical paralytic disease. The other manifestations, what you see in sheep horses, cattle, and pigs have been listed there. In most instances, they can also have either furious forms or neurological manifestations where they can have involvement of the various groups of muscles, depending on which they can develop incessant bellowing and uncontrollable behaviors, abnormal behaviors, etc. Next slide. Yeah. Now, unfortunately, the diagnosis of rabies in animals is delayed in most instances. And in a good number of cases, this diagnosis is made only after the animal has died. That is because for most of the manifestations, except that you see in the dogs and cats, these animals will have behaviors which can actually suggest so many other differential diagnoses. For example, poisoning, hypervitaminosis situations, calcium deficiencies, even meningoencephalitis, various types of viral infections, and there are different types of toxemias have all been suggested, and therefore the diagnosis of rabies in animals is most of the times delayed, except in the case of dogs and cats. Yeah, one question which usually arises is about the consumption of animal products after rabies. Now, it has been shown that the consumption of milk or meat from even animals who have died of rabies is not that risky, but we do not want to recommend that. But suffice to say that pasteurization or proper cooking destroys the rabies virus in most instances. If there's an animal which has been exposed to a rabies, a rabid animal, for example, a cow or cattle or horse which has been beaten by a rabid dog, and if you want to slaughter it, it is recommended that you do the slaughtering immediately so that the virus will not replicate and there is no risk of the virus reaching other parts of the animal body. And if an animal dies of rabies, obviously you will have to practice all barrier precautions in those cases. And obviously, pasteurization, as I said before, pasteurization, boiling, etc., will definitely kill the virus. Therefore, transmission of rabies virus through animals is practically very, very uncommon. So that's all which we wanted to discuss about the human and animal rabies. Thank you very much for your patience. I hope we will have good interaction after the sessions. Thank you very much.
Thank you so much, sir, for this enlightening session on understanding the rabies from bite to brain. It was really insightful to know the nuances of the clinical features and the overall understanding about the picture. So I request you, sir, to look into the chat. If there are any questions, please address those questions in the chat so that we can have time at the end for additional questions. Thank you, sir. So now I request our next speaker, Dr. Ridhamani, Madam, Professor and Head, Department of Neurovirology. Ma'am is heading and member of the WHO Rabies Expert Committee as well as the National Technically Advisory Committee on Rabies under the Ministry of Health and Family Welfare. Her primary areas of expertise include rabies and other viral infections of the central nervous system, emerging viral infections, respiratory infections, and molecular diagnostic techniques. She has authored over 90 scientific publications, including research papers and book chapters, and delivered over 300 lectures at National International Forum. Ma'am is our resource person for the rabies diagnostics and laboratory related aspects. So we are happy to invite you, ma'am, for this insightful session. Over to you, ma'am.
Yeah, thank you very much, and a very good afternoon to all of you as well as the participants. I'd like to thank the Center for One Health for this kind opportunity. The topic given to me is rabies control, prevention, diagnosis, and post-exposure prophylaxis. Next slide, please. So I'd like to cover them under these subtopics. Laboratory diagnosis, I will talk about the need for laboratory diagnosis and antemortem and postmortem diagnostic techniques for human rabies. In prevention of human rabies, I will talk briefly about the post-exposure prophylaxis and the pre-exposure prophylaxis. Next slide, please. Dr. Sajid has very nicely given us a comprehensive overview of the clinical features. So, why is there a need for laboratory confirmation of rabies? as he mentioned, several clinical conditions can mimic a diagnosis of rabies. And some of them include the Guillain-Barré syndrome, which he mentioned can mimic the paralytic form of rabies. Also, post-vaccinal encephalomyelitis also can mimic this condition. In recent years, we are also aware of autoimmune encephalitis, especially the NMDAR encephalitis, which can mimic rabies. There are several conditions which I have listed here, including tetanus, other infections of the brain, acute psychotic disorders, and so on, which can mimic rabies. Which is why it is important to differentiate these conditions for rabies, and we need specific laboratory tests to differentiate or confirm a diagnosis of rabies. Next slide, please. Another reason we need a laboratory confirmation is for patient management and to institute infection control practices, including barrier nursing and so on. We all know that a diagnosis of rabies is extremely difficult for family members to bear. Therefore, laboratory confirmation makes it much more easier for the treating physicians for grief counseling and case closures. Prophylactic vaccination can be initiated in close contacts, which include healthcare workers as well as family members. Dr. Sajit also mentioned to us that rabies is known to be transmitted through corneal and other organ transplants. And therefore, in rabies endemic countries like India, if any person dies of an unknown neurological etiology, it is always better to screen such patients for rabies before their organs are transplanted, to avoid transmission of rabies because of misdiagnosis or a missed diagnosis of rabies. Also, personnel who are engaged in autopsy procedures, embalming, or disposal of cadavers can take additional precautions once we confirm that the patient has died of rabies. Most importantly, we are aware now that there's a global call for rabies elimination uh, by 2030, and when as we move towards the goal, surveillance of rabies becomes extremely important. So the exact burden can be known only when samples are sent for testing. We can also characterize the causative agent, the type of the virus, the variant circulating once a sample comes to a laboratory. For example, we all assume that in India, it's only the rabies virus or the rabies lyssavirus which is circulating and causes rabies in both humans and animals. But that may also be because we have never done much of molecular characterization of the virus in India. And only if we expand this genomic surveillance, we'll be able to identify what are the different Lissa viruses, if at all, which are circulating in India. Also, there are a few regions in the world which are rabies free. For example, in India, as the earlier speaker mentioned, the Andaman and Nicobar and the Lakshadweep Islands are considered to be historically free of rabies. In such areas, it is even more important to carry out a laboratory based surveillance for every single suspected case of human or animal rabies. In fact, just last year, there was the first case of human rabies reported from the Andaman and Nicobar Islands. This happened in the Great Nicobar Islands. The primary health center physician was aware of the symptoms and he suspected rabies, and the sample was sent to us and we confirmed a diagnosis of rabies. Luckily, it was found that the patient was bitten in Jharkhand in mainland India, and then he traveled to the Andaman and Nicobar Islands where he developed rabies. So it was not an indigenous case. But this tells us the importance of constant surveillance for rabies, even in so-called rabies-free areas. Now, rabies in humans can be diagnosed either antemortem or postmortem. What are the samples you need to collect when the patient is alive and there is a clinical suspicion of rabies? So there are 3 to 4 important samples. One is the saliva sample. As we know that the virus is shed in the saliva of an infected person or an infected animal. But this shedding is intermittent, which is why a single saliva sample may not be always sufficient to test for the virus. That is why we recommend at least 3 serial saliva samples collected at an interval of 3 to 6 hours interval and pooled in a single container and then sent to the laboratory for testing. So pooled saliva increases the sensitivity of virus detection. Another sample which we can test is the cerebrospinal fluid or the CSF sample. We can also test a nape of neck skin biopsy, which is called as a nuchal skin biopsy. We all know that since the hair follicles are highly innervated structures, there are higher chances of finding the virus at the uh, root of the hair follicles. That is why we choose the skin at the nape of the neck, because the concentration of hair follicles is quite high in a smaller area of the skin at that site. As shown in the figure, a punch biopsy can be taken at the nape of the neck, which should be at least 5 to 6 millimeters in diameter with about 10 to 12 hair follicles. We can also collect blood samples from the patient. Now remember, please do not add any preservative or formalin to any of these samples and send them to a laboratory in a cold chain with a proper triple packaging, because it's a biosafety hazard. Next slide, please. Now, what tests do we do on these samples? As I said, these are the samples we collect: saliva, nuchal skin, CSF, and blood. I've also put corneal smear here because many of our textbooks mention that corneal smear can be tested. It is true. However, in the recent recommendations, WHO no longer recommends a corneal smear. One, because there are more sensitive and specific tests available. Also, the process of collecting the corneal smear itself can damage the cornea, which is why it is no longer recommended. So, what are the tests we do on these samples? We do a PCR for viral RNA detection in the saliva, the skin, and the CSF sample. Blood is not a good sample for detection of the virus because there is no viremia in rabies. The virus does not get into the bloodstream. In fact, it travels only through the nervous system to the brain. Now, among these samples, saliva, skin, and CSF, which is a better sample for detection of the virus by PCR? A combination of saliva and the nuchal skin are quite sensitive for detection of the virus. Remember, the CSF sample is the least sensitive for detection of virus by PCR in rabies. But a combination of all these 3 samples will definitely increase the sensitivity. We can also do the direct fluorescent antibody test for detection of the viral antigen in the nuchal skin and the corneal smear. But again, as I said, these are not very sensitive tests, and PCRs are always more sensitive. And therefore, even in our lab, we do not do the DFA test on skin and corneal smears anymore. Antibody detection can be carried out on the CSF and blood samples. Now, antibody detection can be done either by an ELISA or by detection of neutralizing antibodies. In our laboratory, we use the RIFID test, which is the rapid fluorescent focus inhibition test for detection of neutralizing antibodies in the CSF and the serum samples. Now, remember, any antibody detected in the CSF is suggestive of a diagnosis of rabies. But if you detect antibodies in the blood sample or the serum sample of the patient, you need to ask whether there is any prior history of rabies vaccination in the patient. If the patient has never ever been vaccinated for rabies prior to this episode, then any antibody in the blood also is suggestive of rabies. But if the patient has had some prior vaccination. In such cases, you can ask for another serum sample after a week or so. And if you can demonstrate a rise in titers, then it is suggestive of a diagnosis of rabies. Now, antemortem diagnosis has its challenges. It's not very sensitive. In our laboratory, we get a positivity of around 40 to 50%. So if you test multiple samples by multiple tests, then the sensitivity might reach up to 80 to 90%. Also, one major limitation of testing antemortem samples is that if any of these tests is positive, it confirms a diagnosis of rabies. But even if all these tests are negative, it still cannot rule out a diagnosis of rabies. So that's a major limitation of antemortem diagnosis, which is why post-mortem diagnosis on brain samples is considered the gold standard, because only testing the brain sample can completely rule out a diagnosis of rabies. Now, how can you collect a post-mortem brain sample? You can either do a craniotomy or cut the skull to collect the brain, which requires consent from the family and may be quite challenging. However, there are other simpler ways to collect the brain sample by the orbital or the transnasal route, or even through the occipital route using lumbar puncture needles. This can help us collect a small bit of a brain tissue, which can be tested in the laboratory. Now, when you collect a brain sample, if you have to transport it to a laboratory which is not nearby, you can transport it in 50% glycerol saline. The brain tissue can stay in this solution and can be transported even at room temperature. However, you can also transport the brain tissue in a cold chain, and that will keep the sample much more viable to be tested. You can also send a part of the brain sample in formalin to the pathology laboratory where histopathology for detection of Negri bodies can be done. But otherwise, you do not have to add formalin if a DFA test or a PCR test has to be done on the brain sample. Next slide. So what are the tests we do for post-mortem diagnosis? So as I said, next, please. Yeah, the brain is the best sample. So on the brain tissue, you can do a DFA test for antigen detection, which is considered the gold standard for diagnosis of rabies, both in humans and animals. You can also do a PCR for viral RNA detection in the brain sample, and it's comparable to the gold standard. You can also detect Negri bodies in the brain by histopathology. But remember that Negri bodies may be negative in about 30 to 40% of the cases. Therefore, if Negri bodies are positive, it's a confirmed case of rabies. But if the sample is negative for Negri bodies, it still cannot rule out rabies. Now, if a brain sample is not available post-mortem, you can still collect other samples which I mentioned in the antemortem diagnosis, like saliva, skin, CSF, and blood samples. And you can do a PCR or antibody detection on these samples. But again, as I said, on any sample other than the brain, if the test results are negative, it does not rule out a diagnosis of rabies. But remember, the gold standard is testing the brain sample. The picture on the top shows the direct fluorescent antibody test, which is done by making an impression smear from a fresh brain tissue and staining it with antibodies to the rabies virus, either monoclonal or polyclonal antibodies, which are tagged to a fluorescent dye. So in this picture, you can see all the apple green particles. They represent the rabies virus as seen under a fluorescent microscope. The picture below shows the Negri bodies, the classical intracytoplasmic eosinophilic inclusions that you see on histopathology. Next slide, please. Yeah, now coming to prevention, as I said, I will be discussing the post-exposure prophylaxis or PEP, which is used immediately following a potentially rabid exposures. We will also discuss about pre-exposure prophylaxis, which can be taken by individuals at high risk of acquiring rabies, mostly due to occupational exposures. Next slide. Coming to PEP or post-exposure prophylaxis, it's a three-pronged approach consisting of wound management, active immunization with rabies vaccines, and passive immunization with rabies immunoglobulins or also rabies monoclonal antibodies that are available recently. Next slide, please. So the first thing you do when a bite victim comes to you is that to ascertain the exposure category, which is defined by the WHO. So category 1 includes touching or feeding of animals and licks on intact skin. Now such exposure does not require any post-exposure prophylaxis, only thorough washing of the exposed area. Category 2 includes nibbling of uncovered skin and minor scratches or abrasions without bleeding. And that requires only wound management and rabies vaccines. Category 3 is the most severe form of exposure, which includes single or multiple transdermal bites, scratches, or even licks on broken skin. Remember, contamination of mucous membranes with saliva or licks also falls under category 3. Now, in this category, you have to administer both the vaccines and the rabies immunoglobulins in addition to wound management. So, in short, remember, if there is bleeding, it falls under category 3. If there is breach in the skin without bleeding, it falls under category 2. If there is no breach in the skin, it is category 1, which does not require any PEP. The next slide, please. Now coming to the rabies vaccines, what are the different types of vaccines available in India? The nerve tissue vaccines derived from sheep brain or animal brain tissues has been discontinued in India long back since 2004. So WHO recommends only embryonated egg-based vaccines and cell culture-based vaccines. And in India, the currently available vaccines are only cell culture based vaccines, which are all equally safe and efficacious. So, the different types of vaccines are listed here. In India, currently, the first two vaccines, that is the purified chick embryo cell vaccine and the purified vero cell vaccines, are more commonly available. Next slide. Coming to wound management immediately after a bite, this is a very simple step, yet most often neglected. So remember, by just thoroughly washing and flushing the area of the bite or the scratch or exposure, we can reduce the risk of rabies by 50 to 70%. So this has to be done for 10 to 15 minutes under running water. Now, if soap is available, soap can also be used. But if soap is not available at the site where the washing is done, it can be done just with plain running water. If disinfectants are available, you can use them. But generally, please avoid covering any of such wounds with any dressings or bandages. That's the reason why even suturing of rabid wounds is generally avoided if it is mandatory to achieve hemostasis. You can suture the wound, but only after local infiltration of rabies immunoglobulins. Wherever indicated, antibiotics and tetanus toxoid can be administered. Next slide. Coming to the route of administration of the vaccine, it can be given either intramuscular or intradermal. Remember that the intradermal route of vaccination is equally safe and efficacious. And in fact, the WHO now encourages the use of intradermal vaccination because it is dose saving as well as cost saving. But there are certain limitations, which is why still it is not as popular as the intramuscular dose. One major limitation is that once the vial is opened, it has to be used within 6 to 8 hours. So unless there are sufficient footfalls in a bite clinic, there is wastage of the vaccine, which is why in India, most of the public facilities use intradermal route of vaccination, but private setups continue to use intramuscular vaccination. Next slide. Now, let us understand what is the dose and site for both the routes of vaccination. For intramuscular vaccination, one dose is always the entire vial of the vaccine. Remember. Now, intramuscular vaccine comes either in a vial of 0.5 or 1 ml, depending on the brands. So, entire vial has to be given as a single intramuscular dose. Whereas intradermal, a single dose is always only 0.1 ml, irrespective of whatever is the intramuscular dose. So is it clear? Intramuscular dose, it's the entire vial, whereas intradermal or ID dose is always 0.1 ml. What are the sites of vaccination? For intramuscular vaccination, the deltoids are the ideal site, but the anterolateral thigh can be used in children less than 2 years of age. The gluteal region is an absolute no-no for rabies vaccination because of the adipose tissue in that region, the rabies vaccine is not absorbed properly, and which delays the immune response. For ID vaccination, again, the deltoids, the anterolateral thigh, or the suprascapular region can be used. Next slide. Now, I will discuss just the regimens which are used in India as per the national guidelines released by NCDC in 2019. There are several regimens which are recommended by the WHO, but I am going to show you only the regimens recommended by the national guidelines in India. So the intramuscular regimen used in India is the ISEN regimen, which is 5 doses of the intramuscular vaccine, a single dose given on days 0, 3, 7, 14, and 28. The ID regimen which is used is the updated Thai Red Cross regimen, which consists of intradermal vaccination at 2 sites on days 0, 3, 7, and 28. So please remember, these are the IM and the ID regimens for post-exposure prophylaxis used in India when it is a primary regimen, which means that in patients who have never taken any rabies vaccine prior. Next slide, please. Now, in patients who have taken a complete regimen of either post-exposure or pre-exposure prophylaxis, but if they get a re-exposure, what is the regimen? Now, remember, if anybody gets a re-exposure and they have taken either a full course of post-exposure or pre-exposure within 3 months of the current exposure, then they do not need any post-exposure prophylaxis, just wound washing. But if the re-exposure has happened beyond 3 months of taking a PrEP or a PEP, then they require only 2 boosters on day 0 and day 3, either by the intramuscular or the intradermal route. And both these doses are single site doses. Now, the best part is in re-exposures, passive immunization is not required. So there is no need to give rabies immunoglobulin or rabies monoclonal antibodies. So that's the best part about a prior vaccination, especially pre-exposure prophylaxis. Next slide, please. These are some facts that all of you have to remember. Day 0 is not the day of the bite. Day 0 is the day when the first dose of vaccine is given. So it has to be calculated from the day when the first dose of vaccine is given. Okay. The vaccine dose in any regimen remains the same for any age group, whether it's a newborn, whether it's elderly, whether it's an immunocompromised patient. So please remember, even for the pediatric age group, it's the same dose. For rabies post-exposure prophylaxis, there is no contraindication because it is life-saving. So pregnancy, lactation, elderly, newborn, no contraindication for rabies post-exposure prophylaxis. Also, as I said earlier, the rabies vaccine should never be administered in the gluteal region. Next slide. Coming to rabies immunoglobulin, we have two products in India, the equine rig and the human rig. The doses are given here. The equine rig is manufactured locally in India and hence is cheap. The human rig is only imported and therefore it's 10 to 20 times costlier than the equine rig. Remember, both of them are equally safe and efficacious, though equine rig carries a very small risk of anaphylaxis because it is heterologous serum. Next slide. Recently, there have been monoclonal antibodies which are launched for the first time in India, anywhere in the world. There are two products, Rabies Shield and Twinrab, which were released in 2016 and 2019. The doses of these are given here. Next slide, please. Now, these have the advantages that they are not serum derived products and therefore the risk of transmitting any infection is nil. There is a more rapid production capability which will take care of the shortages we face while using e-rig or h-rig. It is also less prone to availability, purity and safety issues, and also no skin sensitivity testing is required as we require in the equine rig administration. However, these are relatively new products and therefore WHO encourages the use of these products but recommends maintenance of a registry to monitor the clinical use and outcomes. But so far, whatever data we have, it is shown to be comparable and safe to rig as well as both human and equine rigs. So how do you administer passive immunization? It is mandatory in category 3 exposures, also in category 2 exposures in immunocompromised patients. RIG is administered only once, unlike vaccines, preferably within 24 hours of exposure. But if you cannot give it within 24 hours, you can still give it within 7 days of administration of the first dose of vaccine. After that, it is not of much use because within 7 days, the active immune response following vaccination will kick in and therefore it does not have much utility. Now, how do you administer? The first thing you do is calculate the maximum dose or volume of the rig based on the body weight of the person. Then the maximum volume that is anatomically feasible should be infiltrated locally in and around the wounds as shown in these pictures. Remember, only if the any volume is left over after giving local infiltration, then it can be injected intramuscularly. However, please go to the next slide. WHO in its current guidelines tells us that intramuscular or systemic rig does not offer any additional benefit. Therefore, if any rig is remaining after local infiltration in countries like ours where there's a shortage, it can be given to other patients. There are only certain scenarios where you need to administer the rig systemically. That is when there is a likelihood of additional small wounds which are not seen, or when the exposure is to bats where the exposures are very, very superficial, or when there is mucosal exposure, example, licks on the eyes or oral or nasal mucosa and so on, or inhalation of aerosols in a laboratory or in bat infested caves, or any other non bite exposures where systemic rig can be given. Next slide. Now coming to the last section, that is pre-exposure prophylaxis. This can be given to those who are at continual and high risk of rabies exposure, such as veterinarians, animal handlers, rabies researchers, travelers from non-endemic regions to rabies endemic regions, and also children in rabies endemic countries like us also are a vulnerable population. Next slide. So, what is the regimen for pre exposure prophylaxis that we use in India? It is a single dose of intramuscular or intradermal vaccination on days 0, 7, and 21 or 28. So, it's a 3-dose regimen which is used for pre exposure prophylaxis. Next slide, please. Now, many of you may ask, what is the duration of the immunity? If I have taken one pre-exposure regimen or one post-exposure regimen, should I get any boosters and so on? So the surrogate marker for testing immune response to vaccines is detection of virus neutralizing antibodies. Now, WHO recommends a titer of 0.5 international units per ml or greater than that to suggest adequate seroconversion following rabies vaccination. Now, most healthy individuals achieve this level by day 7 to 14 of any PrEP or PEP. Therefore, regular sero monitoring is not recommended in healthy individuals following both pre or post exposure prophylaxis. However, for professionals at a continual high risk for rabies exposure, periodic monitoring of virus neutralizing antibodies is recommended. And if the titers are less than zero point 0.5 international units, then a single booster of the rabies vaccine is recommended. Generally, if such people cannot estimate their virus neutralizing titers, they can take a single booster of the rabies vaccine either by intramuscular or intradermal route yearly or once in 2 to 5 years. So, vaccine booster doses are not necessary for people traveling to endemic regions or children living in endemic areas. Only such people will require a booster if they have a exposure in future anytime, in which case they need to be given boosters, just 2 boosters on day 0 and 3. Next slide, please. So this is my last slide. You may ask, after giving timely and adequate post-exposure prophylaxis, can a person still develop rabies? So the answer is that in almost 100% of the patients, if timely, appropriate, and adequate post-exposure prophylaxis is given, very rarely the patient will develop rabies. So true PEP failures are extremely rare. The only few cases of true PEP failure we see is especially in children or adults with multiple bites, deep bites on highly innervated areas like the face, the neck, the scalp, fingers, and so on. In such cases, the incubation period is very short, and therefore, any vaccine or rabies immunoglobulin may not be effective, and the patient might still go on to develop rabies. But these are extremely rare scenarios. Most often, the currently available rabies biologics are extremely safe and efficacious. Only when there are deviations in the PEP protocols, for example, incorrect regimen, suturing of the wounds, without giving rig, omission of rig, or delay in initiating the post-exposure prophylaxis, wrong site of giving the vaccine, inadequate dose, and so on, will lead to PEP failures. So, as medical professionals, it is extremely crucial for us to know the exact appropriate regimens that has to be used, and those can save lives in rabies. So thank you. And if there is time, I'll be happy to take any questions. Thank you.
Thank you so much, ma'am, for taking us through the rabies prevention, diagnosis, as well as the post-exposure and pre-exposure prophylaxis, explained in a very simple and understandable manner so that everybody understands the importance and the emphasis on the post-exposure prophylaxis, including the wound washing. Thank you so much, ma'am, for your insightful presentation. Now, I would like to request our next speaker, Dr. Tushar Nale. Sir is Deputy Director in Center for One Health at National Center for Disease Control under DGHS and Ministry of Health and Family Welfare. Sir is accomplished public health specialist with over 15 years of experience in the infectious disease management, epidemiology, digital health, and One Health. He is currently serving as a deputy director at NCDC and dedicated for addressing zoonosis with particular focus on the rabies prevention, control, and integrated in multi-sectoral strategies. He has spearheaded various initiatives through the different infectious disease program like tuberculosis at the Ministry of Health and Family Welfare. With his extensive experience in epidemiology, biostatistics, capacity building, public health policy implementation, he is instrumental in taking this national rabies control program forward in the country. Over to you, sir.
Thank you, Dr. Jitesh. So, previous two speaker has given clinical management, talked about the clinical management and the laboratory diagnosis of the human rabies cases, as well as the animal bite management. So now, as a Yeah, so we will be discussing about the at national level at public, what are the program strategies are there under the National Rabies Control Program. So we heard about the rabies elimination in by previous two speakers and global call of zero human rabies deaths by 2030, dog-mediated rabies deaths. So this is the global call given by the WHO, WOHA, FAO, and the Global Alliance for Rabies Control. So why it is important? So it is 100% fatal, but it is equally nearly 100% preventable. In so latest estimates, if we can see that globally there are around 59,000 people die of rabies each year. 40% of people bitten by suspected rabid animals are children and under the age of 15 years of age. So children are more vulnerable with respect to this getting rabies infection. In 2004, there was a survey by WHO and Association of Prevention and Control of Rabies in India. So it has estimated that 20,000 people die of rabies each year, and most animal bites in India are from 96% are by dog. So whenever we talk about the rabies elimination, we usually generally talk about the dog-mediated rabies elimination. Various countries globally has shown the sustained efforts has we can lead to the decrease in the rabies mortality and eventually the zero rabies death. So recently in year 2019, Mexico is the first country which has been certified as a dog-mediated rabies free country, and our neighboring countries like Bangladesh, Sri Lanka, and Bhutan also had shown that the sustained effort that led to the decrease in the number of human rabies deaths. So that has a global examples, and in our country, Goa and Sikkim are the states which have shown that the One Health approach that leads to the reduction in the number of cases, human rabies cases. Goa and Sikkim, these are the two states which had shown that effort. So these effort has shown that we can have this successful strategy and we can go for the rabies elimination. And based on these various successful examples, we plan for the development of the National Action Plan for Rabies Elimination. Being at the Ministry of Health, we currently, during this webinar, we are specifically talking about the human health component of the National Rabies Control Program. So in 2019, we jointly had one gap analysis and issues, and it has identified gaps. First was the poor surveillance and the reporting, both human and the animal health, about the human rabies cases. The second gap we found as there is a frequent shortage of the human vaccine, and availability of the rabies immunoglobulin is a bit challenging, and these are the very important component of the for the prevention of the human transmission of the rabies, and this was one of the major gap we found during the gap analysis. No formal system for monitoring and reporting adverse events following rabies vaccination. Very few centers with the system of animal bite case follow-up and ensure PAP completion. Latest follow नहीं है क्या? Yeah. General population as well as the updated information in the medical professionals, and there is an unavailability of the rabies beds for the rabies patients. So this is one of few of the gaps we identified, these are the major gaps which we are identified while developing the National Action Plan for Rabies Eliminations, human health component. And based on that, National Rabies Control Program strategies has been identified. Next slide. Yeah, so this National Action Plan for Rabies Elimination, so vision is to achieve zero human deaths due to dog-mediated rabies by 2030, progressively reduce and ultimately enable the human rabies in India, which sustain mass dog vaccination and appropriate post-exposure prophylaxis for the humans. These are the key components. And being an zoonotic diseases, it is not a single sector's responsibility for the rabies elimination. We have human health component and the animal health component, and human health component has the a target or objective is to prevent human deaths to ensuring timely access to the post-exposure prophylaxis for all animal bite victims, and for animal health component, minimum 70% of vaccination coverage dog in a in a defined geographical area targeted for the rabies elimination in a phase-wise manner. Yeah, next slide. Next slide, Lila. Yeah, there is a technological glitch. We are changing the presentation. Yeah, oh, there is sharing issue with the sharing the presentation. Yeah, so based on the gap analysis for the human health component of the National Rabies Control Program, we have these following strategies. First is the strengthening access to the post-exposure prophylaxis for all the animal bite victims, capacity building of the medical and paramedical professionals, strengthening surveillance of the animal bites and the rabies cases in the humans, strengthen diagnostic on capacity on rabies and intersectional coordination and the awareness generation. Next slide. So for any next slide, please. Yeah. So what are the efforts being undertaken by the program for the improving access for the anti-rabies vaccine and the rabies immunoglobulin? So first of all, we incorporated this rabies biological as a part of the essential drug list of the National Health Mission. This mission, inclusion in the National Health Mission's essential. Full screen पे नहीं दिख रहा. Okay.
Just give us 1 minute. There is some technical glitch.
अरे पूरा next. Yeah, apologies for the technical glitch. So, yeah, so to strengthen access for the rabies vaccine and rabies immunoglobulin as a program, first we incorporated these biologicals in the essential drug list so that facilitate the procurement at the state level or the district level. Easy because as per NHM's mandate, a minimum set of drugs that needs to be available at all the health facilities and which are included into the essential drug list. So this was the first step. As a next step, we included this rabies biological as a part of the National Free Drug Initiative. So a few of the drugs that has been identified, the National Health Mission has been available so that funds are being given to the states for the procurement of these rabies biologicals. And last financial year, we almost given 100 crore rupees to the states for the financial assistance is being given to the state through NHM PIP mechanism for the procurement of the anti-rabies vaccine or the rabies immunoglobulin through National Pre-Drug Initiative. As a policy under the program, all the PHC and above health facilities should have rabies vaccination available. Rabies should be available, and CHC and above health facilities should have the rabies immunoglobulin available. Ideally, rabies vaccine and rabies immunoglobulin must be available at the same facility. But then, considering the manufacturing process of the anti-rabies immunoglobulin or rabies serum, it is a serum derived and it cannot be the production cannot be ramped up compared because it is not a tissue culture. We need volunteers and either in the human or the horses required and from their serum we extract this anti-rabies serum and by this is the mechanism for the manufacturing of this rabies immunoglobulin and this cannot be expanded in a large extent and that creates a problem for the production and that is the reason we kept at the CHC, at least CHC and above health facility should have the rabies immunoglobulin. As Madam described, Dr. Ritamani Madam described in her talk about the newer product of the rabies monoclonal antibodies. And recently in the November 2024, few of the safety studies are available in the that has been published and we are working with our technical expert group for these incorporation into our guidelines. For as of now, rabies monoclonal antibodies has not been incorporated into National Rabies Control Program. But yes, we are trying for that based on the available evidences. So current status is almost more say 50% state has the more 75%, at least more than 70% health facilities has the anti-rabies vaccine available at the PHC and above health facility, and the 12 states which has the stock available of the rabies immunoglobulin have the CHC and above health facility. This though it is still a long way to achieve improve the access for the rabies vaccine and immunoglobulin, but then compared to the previous studies like 2017 study, there is a significant rise in the availability of the rabies vaccine and rabies immunoglobulin at the health facility, though there is a long way to go for the further improving the access of the rabies vaccine and immunoglobulin. Next slide, please. Yeah, strengthening surveillance. So we know that there are in 2004 20,000 estimated cases of human rabies were there. Recent ICMR study says that around 5,726 human rabies cases per annum has been to be reported from that has to be estimated from the country, and though we only get around 300 to 400 cases from the field reported from the field, so that for that we are trying to various mechanism for the improving the availability reporting of the human rabies cases, and as a part of this we made a human rabies as a notifiable disease. This is as health is a state subject, it is the responsibility of the state to make human rabies as a notifiable disease, and so far 26 states has reported human rabies as a notifiable disease. We can see that in the left side map that in last 2022 24 human rabies case map district wise. So those states which are reporting properly, or there is a good reporting mechanism, almost every district has reported at least 1 or 2 cases of human rabies in last 5 years, and signifying that there is a regular chain of like ongoing transmission of the human rabies case among the dogs, and that is spilling over to the humans. So we need to focus on all the district, and there is no current specific rabies free areas other than the Andaman Nicobar and the Lakshadweep Island, which has been traditionally rabies free cities. So for strengthening surveillance, first thing we had done is the making the human rabies as a notifiable disease. Next slide, please. We incorporated, developed the case definitions of the human rabies cases, and that has been incorporated at an integrated disease surveillance program. IDSP is one of the largest surveillance program, which includes around 33 disease conditions for the surveillance, and we have developed a specific case definition for the reporting purpose. So probable case is a suspect case dying within days of a first clinical symptoms, or any person with acute encephalitis and at least 2 or following 9 sign symptoms. So these are at par with the WHO or the CDC case definition of the human rabies cases. Laboratory confirmed human rabies case definition has already discussed by previous speakers, so I will not touch on that. Next slide. Yeah, as a part of the human rabies case surveillance, we also trying to strengthen the laboratory network for the human rabies cases. So far 12 laboratories has been strengthened under the program. Out of these, 9 laboratories are functional. 3 new laboratories has been made functional in this will be operational by the end of this financial year. So if you can see that over the years, number of cases or number of sample tested has been gone from 500 cases to almost double, almost 1200 cases has been tested, and we are further pushing for the more and more each and every suspected human rabies case that should be laboratory confirmed for the as we are planning for the elimination, and accordingly we can go for the various allocation of the funds and the policy intervention with respect to the human rabies cases. Next slide, please. Yeah, so capacity building is newer one of the thrust area with respect to for the prevention of the rabies, because timely and appropriate rabies post-exposure prophylaxis is very important, and nursing staff and the medical professional should be aware about the latest guidelines for the rabies post-exposure prophylaxis, which were published in the year 2019, and accordingly through NHM mechanism, various training programs are being undertaken. At the national level, we conduct the national level TOTs, and subsequently a cascade of the training is being conducted for the state and the district level. Next slide, please. We also developed the National Rabies Control website, and where all the technical or the awareness material that has been uploaded on this particular website, so that anyone and everyone can be freely access these resources, including technical presentations or technical guidelines, as well as the awareness material. Next slide, please. Next step towards the ensuring beneficiary tracking for PEP completion and the reporting the adverse events. So we are trying to give the rabies post-exposure post-exposure prophylaxis for the all the animal bite victims, but then compliance is also very important for the prevention of the rabies or developing the rabies in that particular patient. So with the help of the UNDP, we are developing a Zoin portal which has the stock monitoring status, and the also we are planning to have a beneficiary tracking, like those we are who has given the first dose, subsequent dose reminders can be sent to them, and further analysis of that particular compliance report that can be done through this portal. So this particular Zubin portal will be having an inventory management portal which will monitor the real-time stock of the anti-rabies vaccine and the rabies immunoglobulin. Also, it will have logs, individual vaccine administration, and the tracks treatment schedule, facilitates the patient tracking through the unique identifier, ensuring the completion of the full vaccination course, which will also have vaccinator module, quality assurance, and the AE5 monitoring module, and the automated generate reminders and the IAC messaging for the rabies patient, sorry, animal bite patient who was taking the anti-rabies vaccine. Next slide, please. As we know that rabies is a zoonotic 3-TAN joint investigation, which is very much important for the further spread of the disease. So whenever there is a report of the human rabies case in the human rabies case, or either in the animal rabies cases, there are few steps we have been identified. So immediate in case of human health case response is the contact tracing. Whenever there is a human rabies case is reported, we try to identify the animal bite victims which are bitten by the same animal in the same locality, and try to ensure if there is any missed out the post-exposure prophylaxis. Also carry out the public awareness campaign in that particular area, so that those who has missed the anti-rabies vaccine or rabies post-exposure prophylaxis, they can be administered with the appropriate rabies post-exposure prophylaxis. If there is a with animal rabies case, in that scenario, isolation of the suspected rabid dog and the undertaking the mass dog vaccination campaign. So these are the isolated but then linked activity by the human health and the animal health sector. And what is the integrated One Health operation? So what we are doing, these sectors are expected to share the routine information, a surveillance system. Each sector has their own surveillance system, and data sharing parameter has been identified, and they expected to regularly share that particular information with each other, and the subsequent public health intervention that needs to be undertaken. So yeah, so this is on theoretically a very good plan, but then implementation is a challenge because it has different sector has different priorities. But then we are trying to develop few of the mechanism for pushing this One Health approach for the ensuring the case investigation with respect to suspected rabies case, either in the human health or in the animal sector. Yeah. Next slide. Yeah. So to further strengthen this intersectoral coordination and operationalization of the National Action Plan for Rabies Elimination, we are trying to develop state-wise action plan for rabies elimination. And so far, 5 states has already been published their develop and publish their state action plan for rabies elimination. 12 states has drafted their state action plan for rabies elimination, and remaining state we will cover in these subsequent years. So this state action plan for rabies elimination usually is a extension of the National Action Plan for Rabies Elimination. For that, for National Action Plan for Rabies Elimination, around 22 stakeholders, we jointly deliberated and developed National Action Plan for Rabies Elimination. Similar kind of structure or similar kind of efforts are being taken at the state levels. At the state level, Ministry of Health, Ministry of Agriculture, Ministry of Animal Husbandry, Ministry of Panchayat Raj, Ministry of Housing and Urban Affairs, Forest Department, and other stakeholders are involved in the development of this state action plan for the rabies elimination. And through that also we are trying to further strengthen of the One Health structure for the rabies elimination. So far, 5 states has been developed their state action plan for rabies elimination. Yeah, next slide. Another initiative for this particular rabies elimination is the rabies free city initiative. At the municipal corporation level, at least there are few funding is there and few of the in silo activities are being done for the mass dog vaccination or the dog population management, and we want to capitalize that and further streamline particular that activities. So seven tier 1 and 114 tier 2 cities that has been identified, and that will be a part of the rabies free city initiative, which include the mass dog they will develop their own action plan and implement that about the this plan include mass dog vaccination, animal population control, and solid waste management, which are the three requisite steps toward the prevention and the control of the rabies. Annual vaccination of over 70% dog population is proven to be a successful approach to eliminate rabies, and accordingly we are trying to develop few of the strategies with respect to at the level of the city. Yeah, next slide. So these rabies-free city initiative includes action plan preparation, capacity building, awareness generation, resource documentation, and the developing the governance mechanism through joint steering committee and the city task force, which will monitor and or as well as plan for this city action plan for the rabies-free cities. Yeah. So PATH is one of the development partner which is helping us for this rabies free city initiative, and so far till last year almost 15 cities has been targeted for which has developed few of the activities with rabies free city initiative, which include Jaipur, Pune, Mumbai, Cuttack, Bhubaneswar, Ranchi, Manipur, etc. And this scope will further increase in upcoming years for the rabies free initiative. Yeah. To capacity building or generating awareness among the medical officers, we have developed this rabies post-exposure prophylaxis video, and few of the charts are available on the NRCP website or the NCDC website. After this session, we also going to show this particular video. Yeah, next slide, please. Few of the awareness material for general population is also available on the NCD website. We also has this rabies or helpline, which is being piloted in the 5 states, Madhya Pradesh, Assam, Andhra Pradesh, Delhi, and Puducherry, where we try to resolve few of the queries with respect to animal bites, availability of the rabies, rabies vaccine and rabies immunoglobulin. So this is in pilot phase. This has been launched, and based on the findings or the learnings from this pilot phase, countrywide expansion is being planned for this rabies helpline. Yeah, next slide, please. Next slide, please. So these are the various media reports we usually analyze and takes the appropriate actions on them with the help of the state and the district level officers. So this is from my side with respect to National Rabies Control Program, Human Health Component, various activities being undertaken by the program. So thank you.
Thank you very much, sir, for giving us the overview of the National Rabies Control Program and various initiatives taken by the Ministry of Health and Family Welfare towards this fatal disease. So in the talk, as sir mentioned about the various IEC materials, we have the rabies post-exposure prophylaxis film that will give us the idea about the post-exposure. So we are playing that film for reference, as well as we are putting
Rabies is a fatal disease, but timely and appropriate rabies post-exposure prophylaxis or rabies PEP can prevent deaths due to rabies. In India, doctors and healthcare workers treat hundreds of patients every day in hospitals. Today is a usual day at the hospital, but the commotion here is at the anti-rabies OPD clinic where the patients with animal bite are waiting for treatment. Patients visit with different categories of animal bites, such as dogs, cats, monkeys, wild animals like fox and jackal bites in forest areas. Majority of the cases are due to dog bite. There are three categories of dog bite which have been classified on the basis of exposure. Category 1 consists of touching or feeding animals, licks of intact skin, contact of intact skin with secretions or excretions of rabid animal or human case. The category 2 of wounds consists of nibbling of uncovered skin, minor scratches or abrasions without bleeding. The category 3 exposure is single or multiple transdermal bites or scratches, licks on broken skin, contamination of mucous membrane with saliva from licks. In all the three categories of exposure, the first step is wound washing as part of wound management. The wound must be immediately washed up to 15 minutes with soap and water, or water alone if soap is not available to flush out the saliva. In case the victim reports late, the victim should not be deprived of benefits of wound management as long as the wound is unhealed. Disinfectants such as Providone iodine or antiseptic with virucidal activity should be applied. RABV enters the human body by a bite or scratch, so it's critical to get as much saliva and the virus out of the wounds as soon as possible. Ensure not to cause further damage while washing the wound. Let us look at a case study. Geeta is 60 years old and is bitten by a dog on her left arm. She claims she was attacked by a neighbor's dog while walking home.
कहाँ से कुत्ता ने काटा?
पड़ोसी कुत्ते ने काटा है।
पड़ोस का कुत्ता पालतू भी होता है, तभी भी रेबीज हो जाता है। कुत्ता का वैक्सीनेशन हो रखा है, तभी भी हमें काटेगा तो तभी भी हमें वैक्सीन लगाना जरूरी होता है। नहीं तो रेबीज हो गया तो उसका इलाज नहीं होता।
The doctor examines her wound. Her wound falls in category 3 of rabies exposure. The nurse immediately starts PEP, the post-exposure prophylaxis treatment. First, her wound is cleansed for 15 minutes with soap and running water. After washing the wound, the nurse takes her to check her body weight. After calculating her body weight, the nurse carefully infiltrates rabies immunoglobulin or RIG into the depth of the wound and around the wound as much as anatomically possible. Evidence suggests that injecting the remaining RIG volume intramuscularly at a distance from the wound provides little or no additional protection against rabies as compared with infiltration of the wounds alone. RIG should be administered to all patients with category 3 exposure because it provides passive immunity in the form of ready-made antibodies before the victim can produce their own antibodies as a result of vaccination. RIG stops the growth of virus at the site of exposure and inhibits the virus attacking the nervous system of the body. There are two types of RIGs. HRIG or human immunoglobulin are of homologous origin and are relatively free of side effects. Another type of RIG is called equine rabies immunoglobulin or ERIG. It is of heterologous origin produced by hyperimmunization of horses. The dosage of HRIG is 20 international units per kg body weight, and for ERIG, it is 40 international units per kg body weight. Remember, RIG is administered only once, preferably as soon as possible. As per national guidelines, Geeta is also given an anti-rabies vaccine in both her arms. Geeta is still in pain and trauma due to sudden attack. Post the medical treatment, the nurse counsels her to reduce the emotional and physical stress and fully explains about the importance of timely completion of vaccination. Sometimes, in gruesome attacks, the dog bite is inflicted on sensitive areas such as close to eyes, ears, forehead or mouth, genitals, tips of toes and fingers, etc. In such complex cases, rabies immunoglobulin should be infiltrated carefully. Ensure not to put excessive pressure as it can cause compression syndrome. In case the wound requires suturing, then the rabies immunoglobulin should be allowed to diffuse through the tissues and suturing should be delayed for several hours. In case of additional small wounds which may be unreported, injection of the remaining RIG volume intramuscularly as close as possible to the presumed exposure site to the degree that is anatomically feasible is indicated. To prevent sepsis in the wounds, a suitable course of an antibiotic may be prescribed. Let us look at another case study. Sonakshi is here with her mother. She has a small dog bite on her left thigh. It seems like a nibble on the skin and is a superficial, non-bleeding scratch made by the dog. This type of exposure falls in category 2 for appropriate rabies treatment. This wound was already washed by her mother with water and soap. The doctor informs her mother that she will be vaccinated for rabies for precaution. As Sonakshi is still traumatized, the nurse is comforting her before injecting her the rabies vaccine in her upper arms as part of intradermal technique. The intradermal rabies vaccine must be administered through aseptic technique at deltoid muscle for both adults and children. Do not inject in the gluteal region. Vaccines may be inoculated in the anterolateral thigh for infants and small children. As per the intradermal or ID vaccination technique, safely reconstitute the vial of vaccine with the diluent supplied by the manufacturer. Draw 0.2 ml from a 1 ml unit syringe and carefully remove the air bubbles from the syringe, removing any dead space in the syringe. Stretch the skin's surface 1 inch above the deltoid muscle and insert the needle's bevel upwards. Almost parallel to it, slowly injecting half, that is 0.1 ml of the vaccine volume in the syringe into the uppermost dermal layer of skin. You may feel resistance while injecting the vaccination if the needle is correctly inserted inside the dermis. Immediately after the injection, a 3 to 4 mm raised bleb will form. Similarly, the remaining vaccine volume must be administered in the deltoid area on the other arm. Please note that the bleb will not emerge if the vaccination is injected too deeply into the skin. In this case, the needle should be withdrawn and reinserted at a different location, and the ID vaccine should be administered again. The National Rabies Control Program strongly advocates the use of the intradermal route of rabies vaccine over intramuscular route for various reasons. The ID route takes less amount of vaccine to complete the treatment. Since the ID route, all doses of vaccination can be done in one vial, whereas in the IM route, 5 vials are required to complete the vaccination, making intradermal cost-effective and equivalent immunogenic response as compared to intramuscular route. Victim is given 0.1 ml of 2 doses of vaccine on each arm through the ID route. Her mother carefully listens to the nurse, explaining to them the vaccination schedule. Healthcare providers are responsible for informing patients about the need of completing the vaccine dosage on time, both verbally and in writing. The rabies vaccine is given on days 0, 3, 7 and 28 by intradermal route. The first dose of rabies vaccination is given on day 0 to achieve effective immunity against the rabies virus. The vaccination schedule should be strictly followed. Sonakshi is in pain and crying. The nurse advises her mother not to rub the injection site, not to apply anything on it, she informs her mother that there may be tenderness at the injection site and a temporary rise in body temperature are possible side effects that do not require treatment. Now, let us look at a category 1's exposure case. Veer is attacked by a stray dog. The doctor examines him for any invasion or bites or scratches. His skin is undamaged, therefore his type of exposure comes under category 1. Usually in such situations, only washing of the exposed area with soap is recommended and no further treatment is necessary. The healthcare workers should be well versed with the management of 3 categories of wounds and complex cases. A quick recap. Category 1 wound consists of touching or feeding animals and licks on intact skin. Category 2 wounds consist of nibbling of uncovered skin, minor scratches or abrasion without bleeding, and Category 3 wounds consists of single or multiple transdermal bites or scratches, licks on broken skin and contamination of mucous membrane with saliva. In case of doubt, the treatment for the higher category of wound should be administered. The healthcare workers should also explain to the patients that they should not do certain things with the dog bite wound. The most important aspect, do not touch the wounds with bare hands. Do not apply irritants such as chilies, oil, turmeric, lime and salt. Storage and transportation of vaccine and RIG vials is a crucial aspect of rabies vaccination management. Since administration of RIG is mandatory in category 3 types of exposures, the vaccine vials come in lyophilized, meaning freeze-dried and in powder form. It should be kept at 2 to 8 degrees and should be kept out of direct sunlight. The cold chain from transportation and administration should not be broken to maintain the potency of vaccines. Adequate supply of suitable syringes should also be maintained. The medical staff should be well versed in the handling of open vials and proper vaccine storage protocols. During the storage or transit of vaccinations, temperature monitoring devices should be used. The vaccine vial should be stored at room temperature after reconstitution when using ID administration and can be put over an ice pack to maintain the temperature. The total content of the vial should be used as soon as possible and not later than 6 hours after reconstitution. Many questions arise when a person is bitten by an animal. What to do in case a patient misses scheduled doses?
The vaccination schedule does not have to be restarted after 1 or 2 days of deviation. If a patient misses 1 or more of the first 3 doses and does not return on the scheduled dates, additional doses should be administered to complete the vaccine and provide adequate immunity.
What should be the dosage of ID and IM route?
As per guidelines, 0.1 ml of vaccine per site and on 2 sites per visit should be administered on each of the day 0, 3, 7 and 28 through intradermal route. And if we want to give the intramuscular route, entire vial of vaccine is administered on each of the days 0, 3, 7, 14 and 28.
Is it alright to change the vaccine administration routes?
As a routine during post-exposure prophylaxis, changing the administration route from intramuscular to intradermal or vice versa is not recommended. Also, changing from one type of modern rabies vaccine to the other is not encouraged.
Is there any possibility of failure after PEP?
There are occasional human rabies cases reported despite post-exposure prophylaxis due to various factors related to negligence and individual health status. Most of the cases that has been reported due to delayed vaccination or non-use of rabies immunoglobulin in category 3 exposure, or it may also be due to incomplete course of vaccination. Some cases are related to immunocompromised status such as HIV, AIDS, cirrhosis of liver, or use of chloroquine, use of long-term steroids or anti-cancer drugs.
How should one dilute the vaccine?
The vial should be reconstituted as per the instructions on the vaccine vial.
National Center for Disease Control, NCDC, is implementing the National Rabies Control Program since the 12th 5-year plan with an objective to prevent deaths due to rabies in humans. As there is a global call for dog-mediated rabies elimination, the National Center for Disease Control, Ministry of Health and Family Welfare, and the Ministry of Fisheries, Animal Husbandry and Dairying has jointly launched National Action Plan for Dog-Mediated Rabies Elimination from India by 2030. NCDC has also formulated the national guidelines to bring out uniformity in the treatment of rabies and is constantly working to improve surveillance and raise knowledge about rabies amongst healthcare workers and the general public. It is the responsibility of the doctors and healthcare workers to make the animal bite victims understand the importance of timely treatment and complete vaccination, as rabies is a fatal disease. This will make India fulfill its mission to eliminate rabies by 2030.
Close करो। Thank you so much for playing the video. So we have pasted all the links of these IECs as well as the guidelines are available on the website, that is Rabies Free India, which I pasted in the chat box also. So there are many questions. Most of the questions are answered by the experts and some of the questions are yet to be answered. So Dr. Rita Mani ma'am wanted to have some discussion with the participants. So over to you ma'am for answering some of the questions.
Yeah, if you can read out the question, yeah, I can, yeah, I'll start answering whatever, but you can also read. So I can see, is vaccination applicable to pregnant women? So yeah, very important question. I had said in my talk that for post-exposure prophylaxis, there is absolutely no contraindication. So whether it's a pregnant woman, lactating woman, newborn, or elderly immunocompromised person, there is no contraindication because it's a life-saving procedure. Yeah.
And one of the question was regarding the rodent bite with the deep wound. So is this required PEP?
Yeah, so as Dr. Sajit also has shown, and our guidelines say that usually rabies is not transmitted through rodent bites. So the general recommendation is that no PEP is required following a rodent bite. However, many a times people cannot see the animal which has bitten. So in such cases, when we are not aware whether it's a wild rodent or any other animal, it is always better to err on the side of caution. So in rabies, as I think it was said in this video also, when in doubt, over treat. So even if it is a rodent bite and somebody gives a rabies vaccine, it is not going to cause any harm. It may still act as a pre-exposure prophylaxis.
Okay, ma'am. So are some allergies or contraindication for rabies vaccination like egg allergy or something like that?
Yeah, so embryonated egg-based rabies vaccines are currently not available in India. We have only tissue culture vaccines, vero cell-based and purified chick embryo cell-based vaccines. But there can be some that some people are allergic to some components in the vaccine. In such a case, if they have a previous history of allergy to a particular brand of vaccine, we have so many other brands, a different brand of vaccine can be used. We also have a purified G protein vaccine in India, which is launched recently, which is not a whole virus based vaccine, unlike all other vaccines. So that option also is there.
PEP is taken due to the dog bite. And as you mentioned in your presentation that 3 months, within 3 months next bite happens or required PEP, it is not taken. So what is the last point when after which we should take the complete PEP?
Yeah, so remember, after a complete course of PEP or PrEP, the titers may fall maybe after 6 months, but remember the memory B cells persist almost for a lifetime. And any booster given any time in life will elicit a rapid and efficacious immune response. Therefore, if you have taken a complete course, but remember, there should be documented proof available of a complete PEP or a PrEP, in which case you get a re-exposure anytime in life. You just have to take 2 boosters, day 0 and day 3. I think Dr. Sajid wants to add something.
Yes, sir, please.
No, anti-rabies antibody estimation is quite possible in most of the cities these days. So people can actually check their antibody levels and be assured whether they have sufficient antibody levels also.
Right, sir. Sir, most of the questions you answered in the chat also. So can you have one or two responses that you can mention that require everybody should understand? So one of the question was role of immunoglobulin in late vaccination after 72 hours of the bite.
Yeah, so I had said it. See, ideally, it should be given within 24 hours. But it may happen that the rig is not available if the bite has happened in some remote place. In such cases, you can take the rabies immunoglobulin up to 7 days following the first dose of vaccine. Okay. Beyond that, it's not of much use because the active immune response following the vaccine will start by about 7 days post vaccination. So, up to 7 days after the first dose, it can be given.
And ma'am, a period of 3 months that is required, that is considered to be not to be taken as a vaccination or to be taken as a vaccination, starts from the first dose or last dose of the vaccination.
Last dose, last dose.
Right.
Yeah, so antigen is gold standard. Remember, somebody has asked. So, the gold standard for diagnosis of rabies, both in humans and animals, is detection of antigen in the brain. And the test is called as direct fluorescent antibody test because we use an antibody to detect the antigen. Okay? So, detection of antigen in the brain is the gold standard. Yeah, so what about using 3 ID dose? Yeah, so like Dr. Tushar mentioned, please remember the current WHO guidelines in 2018 have recommended many abbreviated regimens. So the 5 dose SN regimen is now converted to 4 doses. The 4 dose ID dose is now the IPC regimen, which has only 3 doses on day 0, 3, and 7. But our Indian expert committee met and they thought that there should be some local evidence with our brands which should be generated before we switch over or change our guidelines. So that is in progress. So maybe in a few months or so, there might be some guidelines which can change.
Yeah, one last question, ma'am. What is the maximum amount of immunoglobulin in case of human as well as equine?
Yeah, so again, I am stressing, see, whatever dosages we have mentioned, 20 international per kg of body weight or 40 international units per kg of body weight, that is the maximum permissible dose, remember. So you have to calculate that volume according to the body weight of the person, and you should never exceed that dose. If that volume is not sufficient to, say, infiltrate you of multiple wounds, and that volume is not sufficient, you can dilute that volume with normal physiological saline and infiltrate all wounds. But under no circumstances should you exceed that dose, because then it might interfere with the active immune response of the vaccines.
Thank you so much, ma'am. Those are the questions put in the chat box. And thank you, sir, for your responses in the chat also, because most of the questions sir has already answered during the chat. So we'll move on to the question answer with the audience that they can answer through the Mentimeter. So request team to go to the Mentimeter. So here the scan code. So participants can scan this from their mobile or just log on to menti.com and use that code given at the top 64969413 so that they can get the question and they can just quickly respond to the quiz so that it can be interactive for everyone. Please show the Mentimeter code. James को बोलो ना, गायब कर दिया उसने. James, please show the Mentimeter code. James का नंबर है. हाँ कोड अभी आ रहा था गायब कोड.
कर रहा होगा कोई करे.
So the participants can scan and join this Mentimeter quiz. Or the link is also pasted in the chat box. They can just click on the link and join directly. If there is code asked by the site, it is 64969413 shown on the screen. We have more than 600 participants and we can see almost 70 are registered on this for the quiz. We wait for next 30 seconds so that most of the participants can log in. There are three options. You can click on the link in the chat box, or you can log into the menti.com in your browser and put the code, or you can scan the QR code. So these three options are there for the login into the quiz. It will not ask any personal information, just the code that is given on the screen. So now we can start with the question. More than 100 participants have logged into the Mentimeter. Requesting James to show the question. So these are the players with various pictures. Which animals are the primary reservoirs for rabies in urban and sylvatic settings? Please click on the correct options. We got 118 correct responses. The dogs and cats are primary in urban settings, and the wolves and foxes and monkeys in sylvatic settings. Next question. What is the primary mode of rabies virus transmission to humans? Please click the correct answer. So most of the have given the correct answer, that is bite from the infected animal. Next question. What are the two clinical forms of rabies in human? Right, maximum has given the correct answer, encephalitic and paralytic forms. Next question. According to the standard case definition for human rabies, which clinical symptoms are essential for diagnosis? Is it a severe headache and fever, paralysis and difficulty in swallowing, acute encephalitis progressing to the paralysis or hydrophobia, aerophobia, the allocated amount of time identified as a buffer to minimize the risk? The answer is C, that is acute encephalitis, progressive paralysis and hydrophobia, aerophobia. Maxim has given the correct answer. Next question. What samples are commonly used for antemortem diagnosis of rabies? Blood stool, skin, urine, CSF, saliva, urine, nail clipping, muscle biopsy, throat flap. So its answer is correct. That is skin, urine, CSF and saliva samples are used for antemortem diagnosis. Next slide. Next question. Which of the following tests confirm rabies infection antemortem? So is it detection of rabies viral antigen, detection by DFA on skin biopsy, detectable rabies neutralizing antibody in the CSF or serum, detection of viral nucleic acid PCR tissue, all of the above? So answer is all of the above. All of the possible positives will be indication of the rabies infection. Next question. In rabies diagnosis, which sample is sent in a viral transport medium? The answer is saliva and corneal smear. Next question. What is the first step in the first aid if someone is bitten by a potential rabid animal? All of you have given the correct answer, that is washing the wound with soap and running water. Next question. What is the role of rabies immunoglobulin post-exposure prophylaxis? The answer is it provides immediate passive immunity. Most of the participants have given that answer. Next question, last. What is the recommended intradermal rabies vaccination schedule for post-exposure prophylaxis in an unvaccinated person? Single dose, doses on 03728, doses on 0721, or dose every month for 6 months. हाँ बताएंगे शायद आएगा ना विनर तो 1 2 3 आएगा. Right, so the correct answer is 03728. That was the last question. So let's see who are top 3 candidates or 4 candidates we can see. These are the results. Dr. Abhishek, who has participated, got maximum points. Congratulations for the correct answers. We can close the quiz. Thank you, James, for the running the quiz. Video on. So with this, we come to the end of this important One Health e-learning session. That is the session number 3 for the rabies clinical features, control strategy, and surveillance mechanisms that is being implemented. So it was attended by more than 2,000 participants. And thank you for your active participations who are there till the last minute of this present seminar. So thank you so much. And we will come with the newer topic in the next month. So keep tracking the NCDC website, NCDC YouTube channel, as well as the Rabies Free India website for more updates. On the behalf of Director General of Health Services, Ministry of Health and Family Welfare, Center for One Health, I like to thank our esteemed experts and faculty for their wonderful and insightful presentations and answering the questions during the interaction session. So thank you so much, Dr. Sajid Kumar sir, Dr. Ritamani ma'am, Dr. Tushar Nale sir, and Dr. Simit Tiwari, Joint Director and Head of the Center for One Health for the this enlightening session. So thank you all. We'll see for the next month for the next e-learning session. Thank you so much.